Assalamu alaikum. Good morning, and thank you again for having me today. In the next 15 minutes or so, I'm going to talk about the role of PET scan in evaluation of microvascular dysfunction. I have no disclosure related to this talk. I'll start with two cases that illustrate the importance of thinking of and evaluating microvascular dysfunction. The first case is a 36-year-old female with hypercholesterolemia, Raynaud's phenomenon, who were referred for evaluation of recurrent episodes of chest pain, clinical examination unremarkable. She has normal kidney function. So her physician rightly ordered a cardiac CT scan, which would, as you can see, pristine coronary arteries. However, she continued to have chest pain, and then later on in the talk, we will figure out what to do with such patient. Another patient is a 66-year-old female who was diabetic and insulin, have hypertension. She reported episodes of exertional chest pain with normal clinical exam despite having a normal SPECT MBI. Now, as we all know, the leading cause of death in our areas, probably similar to Saudi and Pakistan, is cardiovascular diseases. We share the same color, as you can see, and we are among the highest countries of cardiovascular mortality. Interesting enough, although the number of cases referred for myocardial perfusion imaging are the same, the number of cases that are showing ischemia or abnormal SPECT are coming less and less, despite the fact that we have higher incidence of diabetes, have higher incidence of dyslipidemia, higher incidence of metabolic syndrome, and higher incidence of obesity. Likewise, if we look at the rate of obstructive coronary artery disease detected on patients with chest pain, it's interesting that 33% of patients who are men have obstructive disease, and 65% of patients, one-third of patients of men patients referred for coronary evaluation have non-obstructive disease, and 65% of female have non-obstructive disease. So the majority of patients are referred for evaluation of coronary artery disease do not have obstructive coronary artery disease. Even in those with proven ischemia, the rate of having obstructive disease is 97%. So for those patients who are all comers, at least 1 to 2/3 of patients do not have obstructive disease. And in those patients with significant ischemia, 1/4 of them do not have obstructive coronary artery disease. Furthermore, we know from CT studies that if the patient have normal coronary arteries, the minute they present with chest pain, their survival decreases. As you can see in this dark blue line in men on the left side of the screen, women on the left side of the screen, these are asymptomatic men, and these are men who have chest pain and normal coronary artery disease by CT. As you can see, there is a significant reduction in survival in both men and women. So we have patients who have chest pain, do not have coronary artery disease by anatomical evaluation, and yet they are still symptomatic and they are still having low outcome or poor outcome. Furthermore, we know from all the studies that looked at revascularization that patients after having PCI or opening of the artery that thought to cause them chest pain still having significant angina. If we look at these studies as the COURAGE trial, 34%, 1/3. If you look at ischemia trial, 40%, more than 1/3 of patients who have significant ischemia, end up with revascularization of ischemia-related artery, continue to have chest pain from areas that are not thought to be causing their pain, and they are found or confirmed to have non-significant coronary artery disease. So maybe we should be looking at the Phantom of the Opera. And this goes to the fact that whenever we think of coronary arteries, we think of this. We think of the major coronary arteries that are the left main, LAD, circumflex, and PDA, while in fact, this only accounts for 5% of coronary vasculature. The other 95% of coronary vasculature is related to microvascular arteries and arterioles that we cannot see by anatomical evaluation. On top of that, we know from our physiology that the majority of regulation of blood flow happens at the pre-arterial and arteriolar level, probably in capillaries. So if we excluded capillaries, 60% of the regulation of blood flow that results in ischemia happens at the level of microvasculature rather than epicardial coronary arteries that are big and can be seen. Therefore, coronary microvascular dysfunction is a hidden fact in so many diseases that it is probably a significant part of every disease you could think of. It is the primary cause in the regular inoca and myinoca. It can be seen in cardiomyopathies, can be seen in HFpEF. It can be seen also in patients with obstructive coronary artery disease. It can be iatrogenic. It can lead to acute coronary syndrome. It can also be seen in Takotsubo syndrome, in addition to the classical angina that we see without obstructive coronary artery disease. So, in fact, we now know that only 50 to 70% of men have obstructive disease when they have pain, and the majority of women have no obstructive coronary artery disease. And this usually range from inoca, which being detected on myocardial perfusion imaging, to those that have abnormal vasodilation that should be done on PET scan, to those that have vasospasm in patients who should go to invasive coronary angiography, and then of overall endothelial dysfunction that encompasses all of these. So basically, when we look at obstructive disease, we are only looking at the tip of the iceberg, and the majority of the iceberg that is not seen is related to microvascular dysfunction. Why do we worry about coronary microvascular dysfunction? We worry about coronary microvascular dysfunction because there is 4-fold increase in mortality and 5-fold increase in major adverse clinical events. So basically, we are looking at disease that is prevalent in every disease entity that we have, that act primarily to control the blood flow to the myocardium, and is associated with major adverse clinical events. So how do we diagnose coronary microvascular dysfunction? We can diagnose it either by non-invasive technique, which can be done by PET, in which we look at myocardial flow reserve less than 2. It can be done by cardiac MRI, when you look at myocardial blood index of less than 2. And then we have Doppler echocardiography, when we look at coronary flow velocity ratio of less than 2. Can be done by invasive technique, looking at IMR and CFR. But nowadays, it is well understood that PET scan is the gold standard in quantitative assessment of microvascular dysfunction. So how can we do that? As you know, in PET scan, we can do a scan over 20 minutes in which we can image the myocardial perfusion, relative perfusion images. We can look at the gated imaging and assess function and volume. We can also look at microvascular dysfunction, looking at myocardial blood flow, quantitative myocardial blood flow at rest and stress. And we can also look at the coronary calcium score. So combining 3 factors: ischemia, microvascular dysfunction, as well as atherosclerosis. What do we do? How do we do that? We do that by looking at the equilibrium of the tracer in the myocardium. So basically, we inject the body with the radiotracer. That goes first to the RV, then it goes to the LV, and with time, when we reach equilibrium, we can look at the image that can detect the myocardial blood flow per gram per minute. This also has to be taken in account with the kinetics of the radiotracer. As we know, the best radiotracer is the tracer that has a 1 relationship between coronary myocardial blood flow and tracer uptake, and that's only in O15 water, which is unfortunately have a very short half-life, and on top of that, it has to be done in a cyclotron. Now, the other tracer that we use in PET is N13 ammonia and rubidium are so far of being perfect, and with the advent of fluorperidas, probably we'll go in a better way of identifying a good relationship with myocardial blood flow and kinetics. Nonetheless, comparing the ammonia and rubidium to the microsphere, which is done in animal model, you could see that the relationship is excellent with an R of almost 98%. So what do we do with myocardial blood flow quantification? We know that myocardial blood flow is measured at rest and peak vasodilation, sometimes called hyperemic response. Then MFR, which is myocardial flow reserve, is the ratio between stress and rest MFR. Generally, MFR of less than 2 is considered abnormal. However, if we look at the biggest data with 12,500 patients that come from St. Luke Heart Institute of Mid-America, the cutoff probably is less than that, is 1.82. Now, depending on how specific or sensitive you want to be, you could consider 2 or less than 1.82. Now, severely reduced MFR of less than 1.5 may indicate multivessel disease, and balanced ischemia should be taken in account. And MFR of 1 to 1.2 may indicate inadequate response to vasodilator and non-diagnostic study. And we know that PAT now is the gold standard of non-invasive evaluation of microvascular dysfunction. So what do? This is what happened with the myocardial blood flow. In resting condition, you have an equilibrium. But if there is an increased demand, your myocardial blood flow should increase, as you can see in these ranges below lines. And if there is decreased blood demand, then the myocardial blood flow is decreased. So we have a dynamic process. And of course, the red line is the hyperemic response that we do with exercises. So in order to diagnose coronary microvascular dysfunction, we have to calculate myocardial blood flow. And then we just divide myocardial stress or peak or hyperemic myocardial blood flow by rest. And if it is less than 2, it indicates CMD. However, one has to keep in mind this is a ratio. So one has to be cognizant of the fact that rest myocardial blood flow should be increased, and the normal value is between 0.07 to 1.2. And one has to look at normal peak myocardial blood flow, which is 2 to 2.5. So we have to combine these 3 measures in order to identify microvascular dysfunction. So this is the graph that we've seen earlier, but remember that myocardial blood flow reserve, which is the marker of microvascular dysfunction, can be decreased because of the decreased hyperemic or stress myocardial blood flow. And this happens in hypertension, dyslipidemia, smoking, diabetes, metabolic obesity, and hypertrophic cardiomyopathy. Likewise, it can be low because of increased rest myocardial blood flow that is related to a blood pressure pulse product, which is hypertension, fast heart rate, obesity, and anxiety. And as you can see, all these 2 are totally different from each other, and one has to be cognizant of the fact that they may not resemble the same outcome. This is why the proposed microvascular dysfunction subtypes are divided into 4 groups. 2 major groups are the classical type and indigent type. In the classical type, we have to look to a normal. When the normal is when the myocardial blood flow at stress and myocardial blood flow at rest are normal, and the classical CMD, which is related to much worse outcome, is when the MFR is reduced because of decreased myocardial blood flow stress. So basically, impairment of the ability of the microvasculature to dilate in response to need. And these are the ones that we worry about the most. Now, the indigent type, there is a decrease in both stress and rest, and this results in normal. So the ratio is normal not because the patient is normal, but the patient has both reduced myocardial blood flow as stress and rest. And this is a type that is probably need to be more and more identified, and further data should be looked at the outcome of these patients. And then we have the coronary microvascular dysfunction of indigent type, in which the rest scan is very high. And those, as I said, are the patient with high blood pressure, anxiety, and obesity. And probably because of their increased blood flow response and metabolic milieu, they have worse outcome. Now, there are things to keep in mind when interpret this data. First, if there is minimally increase in peak flow, one should be consider inadequate response to vasodilator, rendering the test non-diagnostic, and probably should not comment on ischemia, microvascular dysfunction, or the presence of coronary microvascular dysfunction. When there is low normal peak flow, this may be considered normal in elderly patient because they have less response and less vasodilatory response, but should alert you in young patient and should be considered abnormal. And then in very low peak flow, then one has to be thinking of severe coronary microvascular dysfunction or significant epicardial coronary artery disease. And when I'm talking about very low peak flow, we're talking about a ratio of less than 1.5, in which there is a 56% chance of having significant coronary artery disease. Therefore, it is prudent sometimes to rule out significant coronary artery disease with anatomical evaluation before we can differentiate between these two types. Now, remember that incorporating calcium score in the diagnosis is essential. If I have seen a patient with severely reduced flow reserve, but the calcium score is very low or or zero, then the likelihood of patient having coronary artery disease is very, very low. It is not excluded, but it is extremely low. If we consider, we have to consider anatomical evaluation in those patients to rule out significant coronary artery disease, particularly if the likelihood of the disease is very high. And then we have to remember that PET only evaluate patient with impaired vasodilation, which is one end of the spectrum of microvascular dysfunction, and the other end is actually the vasospastic, which is increased vasospasticity, which unfortunately we cannot do with PET. We have to do it with acetylcholine challenge test. But luckily, only 15% of microvascular dysfunction are at the end spectrum of vasospastic. So you could argue, if I do the patient and he's doing well, I can use vasodilatory drug as empiric treatment, and if he gets well, then obviously I can consider patient diagnosis without subject them to invasive coronary angiography. So back to our cases. So you remember our case was a young patient with hypercholesteremia, Raynaud phenomenon. She had pristine coronary artery, as you know, but unfortunately, she continued to have chest pain. So what we decided, because she is very young, we decided to do a regadenoson stress CMR. And this is her function. As you can see, she has normal function, normal volume, normal contractility. But when we did the perfusion, could see here that she has significant perfusion defect in the apical segment, indicating inoca. Therefore, this patient actually has microvascular dysfunction that can be easily missed in a patient with normal coronary arteries. Now, our second patient was who was diabetic, hypertensive, episode of chest pain despite a normal SPECT. Because of her older age, we consider her for PET scan. This is his myocardial perfusion imaging, and as you can see, it's basically normal. There is no relative perfusion abnormality, no TID, and then her ejection fraction augmented, and there was no regional wall motion abnormality. But look at what happened when we did her CFR. Her resting flow are normal, but she has significant reduction of stress or peak or hyperemic vasodilatory response, resulting in severely reduced flow reserve. And because of that, we decided, because of her risk factor, age, and severely reduced, we thought that we should probably rule out significant epicardial coronary artery disease. And this is her coronary anatomy, which showed normal coronary anatomy. Therefore, we concluded that this patient has severe coronary microvascular dysfunction. So in conclusion, ladies and gentlemen, coronary microvascular dysfunction is increasingly recognized across the entire spectrum of cardiovascular and metabolic diseases. One should think of it whenever there is a patient who has classical symptoms or unexplained symptoms despite a good or normal anatomical evaluation. PET is a robust tool in the diagnosis of coronary microvascular dysfunction. In fact, it is the gold standard in the non-invasive evaluation through the quantitative assessment of myocardial blood flow. PET provides an accurate diagnosis of impaired vasodilation indeed, but not vasospastic, so one should keep it in mind. But luckily, this only accounts for 15% of patients with microvascular dysfunction. And now PET provides insight into the essential type of coronary microvascular dysfunction. So not only we diagnose it, but we can differentiate between indigent type and classical type, which carries prognostic value. And with that, I thank you for your attention, and thank you again for having me and giving me the privilege to be with you this year. And hopefully in the next events, I will be in person with you in the lovely Pakistan. Thank you so much.